no, this is what your heart beats for, but unless your stethoscope is from Central Park, this is what actually the heart sounds like. Assalamu alaikum and welcome to another video of Learn with Laraib. Today's topic is heart sounds and murmurs. Before we begin with today's topic, here's a quick quiz for you. I will play the sound and here are the features written. Please guess what murmur it is. If you got the answer, that's very good. But if you did not, I'm not going to give you the answer just yet. You will figure it out yourself as we go, just like how you should approach your MCQ practice, and trust me, it sticks better. Now, you won't get audio clips in FCPS, but if you understand where, when, and why this murmur happens, you will never forget it. And that's the point. We are not just memorizing, we're building a clinical sense you'll need in every MCQ even when the stem changes. So today we will be discussing, as I just said, heart sounds and murmurs. Let's start with the heart sounds. Before I move on to the lub you probably heard at the start of the video as well, let's see in which area, which valve you can listen to. So as we all know, heart has four chambers, four valves, semilunar valves, two semilunar valves, two atrioventricular valves. So first semilunar valve is aortic valve, which is present over here. Then we have pulmonary valves. So aortic valve can be heard in right second intercostal space. Pulmonary valves can be heard in left second intercostal space. Tricuspid valves is heard in between the fourth and fifth rib at the left border of the sternum. Mitral valve is heard at the left fifth intercostal space in the mid-clavicular line. So these were the valves. Let's see what heart sounds we have. So normally everyone knows we have S1 and S2. These are the normal heart sounds. Then we have added sounds, that is S3 and S4. So this is a diagram, S1 and S2. Start of S1 till start of S2 is systole, and start of S2 till the other S1 is diastole. S1 is generated due to mitral and tricuspid closure. It is heard loudest in mitral region. Now, if you remember in cardiac cycle, we did a diagram, and if you pull up your first aid, you can see the diagram. At the start, where the mitral valve closes, there is an S1 sound. So it happens is in isovolumetric contraction at the very start of it. And in ECG, it's the start of QRS wave. These are MCQs, so please remember these. So S1 marks the beginning of systole. Now S2 is produced due to closure of aortic and pulmonary valve. It marks the beginning of diastole and isovolumetric relaxation. Now S2 has splitting of sound. This is basically the physiological splitting is caused due to inspiration. So due to inspiration, the intrathoracic pressure drops, the venous return increases, and there is then a delayed closure of pulmonary. So पहले जो sound आती है A2 and then P2. Aortic valve and then pulmonary valve. So this is S1, this is A2, this is P2. This was physiological splitting. Now, the pathologies, one variant is white splitting. White splitting means A2 की आवाज आ गई है and then there is a gap between P2. Longer gap. That can occur if there is an issue with pulmonary valves because A2 की तो आवाज normally आ रही है, issue pulmonary में आ रहा है. क्या हो सकता है? Pulmonary मतलब वो late close हो रहा है. There is a louder voice, so pulmonary stenosis. और right bundle branch block. Right heart जो है, that's pumping late. Then the other variant is fixed splitting. So we initially talked about that we will hear the splitting in inspiration, but in fixed splitting, inspiration और expiration दोनों में equal splitting है. That happens in ASD. So the other fourth variant is paradoxical splitting. That means the splitting in verses. So पहले paradoxical मतलब उल्टा हो जाता है. पहले P2 आती है, बाद में A2 आती है. And there is a gap during expiration as well. This occurs due to aortic stenosis and यहाँ पे right bundle branch block था, तो यहाँ पे left bundle branch block आ जाएगा. So this was S2. Now moving on to S3. S3 is heard in early diastole, as you can see over here in the diagram. S4 is heard in late diastole, basically atrial systole. This is early diastole. So S3 is best heard at apex. It is caused due to increased filling pressure. S3 is often normal in children and pregnancy. However, it is almost always abnormal in adults. Some athletes might have it normally as well. Now, S4 occurs, as we told you, in late diastole or basically atrial systole, and it occurs because the ventricle, the left ventricle, is stiffened. Let's say in left ventricle hypertrophy. इसमें जब blood आके लगता है, it causes another sound that is S4. So it is associated with ventricular non-compliance. Let's move on to murmurs. Okay. So understanding murmurs is very easy. Just follow along what I'm going to tell you. Now we all know how heart works, diastole and systole. Whenever there is a systole, heart is pumping blood out of the ventricles. Aortic and pulmonary valves will open and atrioventricular valves will close. So there are two things valves से related. Either it's a regurgitation or it's a stenosis. या valve weak हो गया, regurgitation हो रही है, या फिर वो thick हो गया, stenosis हो रहा है. So systole में अगर regurgitation हो रही है, that means the blood is going back. It can only go back from a place where it is closed. So atrioventricular valves are closed at that moment. इसका मतलब है वहाँ पे regurgitation होगी अगर murmur create हो रहा है systolic. So mitral and tricuspid regurgitation are systolic murmurs. Now for aortic and pulmonary valves, since they are already open, तो उसमें regurgitation तो नहीं हो सकती systolic pressure में. So systolic murmur for aortic and pulmonary valves are this aortic stenosis and pulmonary stenosis. Since the valves are thickened, blood उनको और जोर से hit करेगा and it will create turbulence, it will create a murmur. So aortic stenosis and pulmonary stenosis. Another thing that you can learn is ASD and BSD. Both of these are systolic as well. Now, I can go into much detail for these, but it is not as important for you right now. Now, for diastolic murmurs, just think the opposite. The atrioventricular valves are open and the semilunar valves are closed. अब अगर aortic और pulmonary valves closed है, यहाँ से regurgitation possible है. That means यहाँ पे aortic and pulmonary regurgitation होगी. और दूसरे valves जो खुले हुए हैं, that means tricuspid and mitral valves, उनके stenosis होगा. If there is a pathology that is creating a murmur, it will be this murmur. ज़रूरी नहीं है हर time पे होगा. So let's go in a little further detail. we'll start with aortic stenosis. This kind of murmur, we all know it's systolic murmur. अब aortic stenosis है, that means के शुरू में ही हो जाएगा. जैसे ही heart pump out होगा, aortic valves के साथ लगेगा, and it will create a murmur. It will be ejection systolic murmur. All right. The sound it will produce will be a crescendo, decrescendo murmur. A lot of places mention it as diamond shaped as well. This is the sound waveform shape. It's an aortic murmur. It will be heard most loud at S2 level, that is the aortic level, and it radiates to carotids. It will produce a paradoxical S2, as we just learned in the heart sounds as well. Also, whenever you measure the pulse of a person with aortic stenosis, they will have a slow rising pulse. Again, aortic stenosis happens because of thickening of valves, so it is related to calcification in older people, and it can further lead to syncope, angina, and dyspnea on exertion. So whenever a person exerts, usko blood उस तरह से pump नहीं होगा, it will cause these three. It may cause these three. And the mnemonic for it is SAD. All right. Now we will be moving on to mitral and tricuspid regurgitation. Again, there are a type of systolic murmur. Ab regurgitation throughout the systole hogi, so this will be a pan-systolic murmur. This is mostly created due to ischemic heart disease, mostly post-MI, or due to left ventricular dilation. Left ventricular से mitral regurgitation होगी, and right ventricular dilation से tricuspid regurgitation होगी. The tricuspid regurgitation murmur radiates along the sternal border. So you might see an MCQ as pansystolic murmur, which radiates along the sternal border. Now, sternal border say we might get confused with aortic regurgitation, but keep in mind they're talking about a pansystolic murmur, not a diastolic murmur. So the answer will be tricuspid stenosis. Sorry, tricuspid regurgitation. Now moving forward to aortic regurgitation. I'm just discussing the most important ones with you. Rest of I've just given a basic information. So for aortic regurgitation, this is an early diastolic murmur. It produces decrescendo murmur. It has a famously known pulse type, which is collapsing pulse or water hammer pulse. Now, this is a very important MCQ. So, aortic regurgitation then progresses to heart failure. So, during diastole, the aortic valves should be closed. But in aortic regurgitation, it's incompetent, so the blood leaks back from the aorta into the left ventricle. There's a volume overload in left ventricle, and due to that, there is an increased end diastolic volume in the left ventricle eventually, which causes the left ventricle to dilate and hypertrophy occurs of the left ventricle. This is compensation, which increases the wall stress and myocardial oxygen demand in the left ventricle. Due to increased wall stress and progressive systolic dysfunction, the left ventricle can then no longer maintain the forward output. The ejection fraction will drop and the systolic heart failure will begin. The causes for aortic regurgitation include bicuspid aortic valves. It's usually tricuspid. Endocarditis, aortic root dilation. So root बड़ी हो जाएगी, valve छोटा पड़ जाएगा. And rheumatic fever. One important thing to notice, whenever there is an MCQ regarding rheumatic fever, it's most likely to be connected with mitral valve disease, since rheumatic fever affects mitral valve first and then the other valves. A mnemonic for this is beer. इससे पहले हमने एक और mnemonic किया था, SAD, the consequences of atrial stenosis, and beer is for causes of aortic regurgitation. Now moving on to mitral stenosis. So mitral stenosis is a mid-diastolic murmur. It's a sequelae of rheumatic fever. Rheumatic fever and mitral stenosis are very much related. So whenever there is mitral stenosis, that means the mitral valve is not working properly. That means that atria is being filled up more than it usually has to, which causes left atrial dilation or left atrial hypertrophy. Due to that, since atria में blood आ रहा है pulmonary circulation से, it pushes back blood into pulmonary circulation, causing pulmonary congestion and pulmonary hypertension. And then when it's further advanced, it causes right ventricular hypertrophy and right heart failure. It's a mid-diastolic murmur, which leads to pulmonary congestion and right heart failure. Now, one more thing. When there is mitral stenosis, it causes left atrial dilation. When the atria is dilated, it is not contracting fully, which will cause atrial fibrillation. So a person is more prone to right heart failure, pulmonary congestion, and atrial fibrillation altogether in mitral disease. All right. Another type of murmur is PDA, which is patent ductus arteriosus. So this is a machine-like murmur. Whenever you hear of a machine-like murmur, think of PDA. This is neither systolic nor diastolic. It is continuous in nature. It usually occurs in young children or adults. Now, moving forward, I would like to discuss a very important condition with you, that is mitral valve prolapse. This one also creates a murmur, and it's similar. It basically leads to mitral regurgitation, and it creates a systolic murmur. The mitral regurgitation has a pansystolic murmur. Mitral valve prolapse has a mid-systolic murmur. You might often hear it as written as mid-systolic click. Now, what is mitral valve prolapse? It is a condition when the valves do not close properly. Instead of closing tightly, one or both the valves leaflet bulge backward, that means prolapse backward into the left atrium during the systole. Now imagine there is a double door which is trying to shut tightly, but during pressure, one flap swings backward, that's prolapse. It occurs due to the mitral valve being floppy. That can be due to myxomatous degeneration. Now, this can be due to connective tissue disorder, Marfan syndrome, Ehlers-Danlos syndrome, anything. This is primarily degenerative, and secondarily, it can be due to changes in left ventricular size or shape. Now, this is an MCQ, so keep this in mind. So this was all for mitral valve prolapse physiology. And one thing I would like to add before I conclude the murmurs is a bonus point for you in aortic regurgitation. So the chest X-ray in aortic regurgitation will show cardiomegaly and pulmonary congestion. Why? Because we talked about heart failure, and these two will be shown on chest X-ray as well. And yes, they will be present in mitral stenosis as well. Another thing I wanted to discuss with you is how different maneuvers impact the murmurs. So whenever a person is standing or performing a Valsalva maneuver, the pre-note decreases and the left ventricular volume decreases as well, which causes an increase in mitral valve prolapse, while the other murmur sounds decrease comparatively due to this maneuver. तो ये आपने याद रखना है स्टैंडिंग और वल्सल्वा में क्या होता है एंड वाइस वर्सा होता है पैसिव लेग रेज एंड स्क्वाटिंग में which is that the most murmurs increase and MVP decreases. When a hand grip is formed, the left-sided murmurs, which are aortic regurgitation, mitral regurgitation, and VSD, they decrease while the other left side murmurs increase. This is because of increased venous return to the right heart. During inspiration, this one is important as well. These two are MCQs. So during inspiration, there is increase in venous return to the right heart. So most right-sided murmurs increase with expiration. Inspiration, this is wrong over here. And most left-sided murmur increase with expiration. Okay, now I would like to tell you some bonus MCQ points regarding S1 and S2. So S1 is always longer than S2. The sound is longer. However, S2 always has high frequency than S1. All right. Also, if there is a loud S1, once it occurs in mitral stenosis, the PR interval on ECG is less than normal. And S1, as I told you before as well, it's related with QRS wave, isovolumetric contraction, and C wave on the JVP curve. So this was all for today. Did you figure out the answer yet? If you did, drop your answers in the comments and let's see if you got it right. I'll reveal the correct diagnosis in the next video, so make sure you subscribe and have the bell icon turned on. Thank you.